insect vectors of human diseases: lymphatic filariasis, malaria, and dengue. Lymphatic filariasis, here you can see a picture depicting that condition. Definition: lymphatic filariasis, also known as elephantiasis, is a parasitic infection caused by filarial worms transmitted through mosquito bites. The worms affect the lymphatic system, leading to chronic swelling, skin thickening, and in severe cases, disfigurement. Transmission: Wuchereria bancrofti, Wuchereria malayi, Wuchereria Brugia thymori, Lua Lua, and Onchocerca volvulus. So, Wuchereria bancrofti, Wuchereria malayi, Brugia thymori, Lua Lua, and Onchocerca volvulus. Among these, the last two are responsible for elephantiasis. The first two are very common in India. Wuchereria bancrofti causes Wuchererian or Bancroftian filariasis, Wuchereriasis. So, WHO report since WHO report since 1992 show that there are nearly 25.47 million microfilariasis cases in India, carriers, and 25.47 million. Okay, with 19.36 million showing symptoms of filariasis. Filarial worms are endemic in UP, AP, Bihar, Orissa, Gujarat, Tamil Nadu, and Kerala. Endemic to these regions. Life cycle: Bancrofti complete its life cycle in two hosts: definite host, that is human; intermediate host, mosquito, belonging to genus Culex, Aedes, and Anopheles. Life cycle in human: entrance in the human and development into adult worms. Infection is occurred by the bite of infected mosquito, during which L3 larvae are deposited on the skin. The L3 larvae are not directly injected into the bloodstream. The L3 larvae are deposited on the skin near the site of puncture. Later, attracted by the warmth of the skin, the larva enters through the puncture wound or penetrates through the skin on their own. The L3 larva, after penetrating the skin, reaches the lymphatic channels, settles down at some spot, inguinal, scrotal, or abdominal lymphatics, and then lymph metamorphose and becomes sexually mature. The male fertilizes the female, and gravid female discharge microfilariae, which usually appear in the peripheral blood in 8 to 12 months of infection. These microfilariae circulate in the blood for 6 months to 2 years and then die if not taken by mosquito. And life cycle in human: entrance in the human and development into adult worms. Infection is occurred by the bite of infected mosquito, during which L3 larvae are deposited on the skin. L3 larvae present, and the L3 larvae are not directly injected into the bloodstream. They are deposited on the skin near the site of puncture, but are not directly injected into the bloodstream. Later, attracted by the warmth of the skin, the larva enters through the puncture wound or penetrates through the skin on their own. Then this microfilariae is formed, as we mentioned earlier. So these circulate in the blood for 6 months to 2 years and then die if not taken by mosquito. Life cycle in mosquito registers the development of microfilariae. Microfilariae ingested by the mosquito lose their sheath within 2 to 6 hours of their arrival in the stomach. Microfilariae ingested by the mosquito lose their sheath within 2 to 6 hours of their arrival in the stomach. They then penetrate the gut wall and migrate to the thoracic muscle, where they rest and begin to grow. In the next 2 years, microfilariae become thick, short, sausage-shaped with a short, spiky tail measuring to 124 to 200 mm in length, 10 to 17 mm in breadth, and this is the first stage larva, L1. The larva possesses a rudimentary digestive tract. During 3 to 7 days of time, the lava grows rapidly, molds once or twice, and measures 225 to 330 mm in length. In the next 2 days, microfilaria become thick, short sausage shaped with a short spiky tail measuring to 124 to 200 mm in length and 10 to 17 mm in breadth. This is the first stage lava L1. The lava possesses a rudimentary digestive tract. During 3 to 7 days of time, the lava grows rapidly, molds once or twice, and measures 225 to 330 mm in length by 15 to 30 mm in breadth. This is the second stage larva L2. Okay, then metamorphosis completes by 10 to 11 days with distinct features such as the tail atrophies to a mere stump and digestive system, blood cavity, body cavity, and genital organs are now fully developed. This is the third instar larva L3. These L3 larvae metamorphosis completes by 10 to 11 days with distinct features such as the tail atrophies to a mere stump. So during 3 to L3 stages there, so these L3 larvae are the infective form which enters the proboscis and sheath of the mosquito on or about the 40th day. When the mosquito bites a man during the blood meal, the L3 larvae are released from the tip of proboscis of mosquito and the cycle is repeated. Development of mosquito take place within 10 to 20 days. Life cycle of lymphatic filariasis. First stage, find out one. Yeah, human stages. An infected mosquito deposits larvae on the skin while biting, and the larvae enter the wound. An infected mosquito starts the cycle. Then larvae migrate to vessels and nodes of the lymphatic system where they develop into thread-like adult worms. Three adult worms, which typically live 5 to 7 years, damage the lymphatic system, causing infections that result in blockages, swelling, and fever. Lymphatic system blockage, swelling. Then fertilized female worms release embryonic offspring called microfilaria. Fertilized female worms release embryonic offspring called microfilaria that enter the bloodstream. They circulate at night when mosquitoes bite in blood vessels near the skin. Another mosquito becomes infected, continues the cycle. Fertilized female worms release embryonic offspring called microfilaria that enter the bloodstream. They circulate at night when mosquitoes bite in blood vessels near the skin. And then another mosquito become infected, continuing the cycle. A mosquito feeding on the blood of an infected person ingests microfilaria and become infected. In several stages, inside a mosquito's midgut, microfilaria develop into infectious larva. L3 larva is there. L1 larva to L3 larva. The larvae migrate to a mosquito's head and proboscis sheath. These mosquito stages are there. Okay, this red colored ones are mosquito stages. Black colored ones are human stages. Lymph nodes and vessels, bloodstream. Pathogenesis. Though L3 larvae are infectious larvae, they do not have any pathogenic effect. Similarly, circulating microfilaria are also not pathogenic. The pathogenic effects are due to the fourth larval stage, molting stage from L3 and adult worms, whether living or dead, present in the lymphatic vessels. The following stage occurs sequentially during the pathogenesis or lymphatic filariasis: dilation of lymph vessels, the developing larva, and metabolic products released during the molting of the larva, unsheathing of microfilaria during molting, and presence of the adult worms induces inflammatory reactions. So the following stages occur sequentially during the pathogenesis of lymphatic filariasis: dilation of blood vessels, the developing larva, and metabolic products released during the molting of the larva, unsheathing of microfilaria during molting, and the presence of adult worms induces inflammatory reactions. The intense inflammation of lymph vessels leads to dilation of lymph vessels during the early stage of infection. Besides inflammation, Immune reaction of a host against the worms and toxic effects of the worms also results in dilation of lymphatic vessels. Dilation of lymphatic causes an increased secretion of proteinaceous material from lymphatics into the surrounding tissue, leading to the inflammation of conspicuous lymphedema and thickening of the endothelium. Any inhibition of lymphatic vessel, lymphatitis, lymphangitis. It is characterized by the presence of dilated, inflamed, thickened lymphatic vessels associated with the erythema, edema, and tender painful areas. The main causes are irritation caused by the movement of the adult worm inside the lymphatic system, release of metabolic wastes by larvae, absorption of toxic wastes liberated from dead worms by host cells. Then secondary bacterial infection, streptococci, obstructions of the lymph node. The lymphangitis is followed by necrosis, sclerosis, and obstruction of lymphatic vessels proximal to the lymph nodes. Flow of lymph is obstructed due to presence of worm in the lymph vessels, thickening to lymphatic vessels, as well as focal necrosis, giant cell formation, fibrosis, as well as cellular changes result in obstruction of lymphatic vessels. The obstruction of the lymph flow results in the elephantiasis, which is the classical feature. The course of the events and the pathogenesis of the lymphatic filariasis are variable and depend upon interaction of a variety of host and parasitic factors. In stages, endemic normal, no overt clinical symptoms. Asymptomatic stage, person in this stage have microfilaria in their blood but do not show any clinical manifestation of filariasis. They may remain asymptomatic for years or even after life. Acute filariasis or inflammatory phase is caused by antigens released from female adult worms. Chills, general malaise, headache, and pain are other symptoms. Lymphedema, lymphadenitis, adenolymphangiosis. Chronic filariasis is obstructive phase, usually takes 10 to 15 years to develop. Typical manifestation includes lymph-varices caused by the obstruction of lymph flow and accumulation of lymph in the ducts, leading to dilation of the ducts. Then hydrocele caused by obstruction of the lymph vessels of the spermatogonia and exudation from the inflamed test and epidermis. Elephantiasis, it is a result of Hurarian infection and usually follows years of continual infections. Hypertrophy and hyperplasia seen as a result of excessive protein in the lymph exude, stimulating the connective tissue to excessive growth. Elephantiasis in the scrotum, legs and arms of male and legs and arms of the female is a feature of chronic elephantiasis. The affected part becomes enormously enlarged, producing a tumor-like solidity. The surface of the skin becomes rough and even papillomatous. The hairs become rough and sparse. On section, the skin is cut like an unripe pear. It's thickened, dense, and fibrous. The subcutaneous tissue shows a blubbery appearance in which the dilated and thickened lymphatics and veins can be seen. The underlying muscles and bones do not usually show any alteration. Then granuloma of breast, characterized by the presence of film, solitary mass in the breast. Then chyluria, urine shows chyle mixed with blood, and occasionally a microfilaria caused by escape of chyle through the urine due to the rupture of varicose chyle vessel through the mucous membrane of the urinary tract. Less frequent lesions, this includes granuloma of the spleen and other organs, and the presence of adult Huraria bancrofti in the anterior chamber of the eye. Occult filariasis. Identification clinical symptoms. Look for common symptoms like swollen limbs, especially in the lower extremities, recurrent fevers, and enlarged lymph nodes. These clinical signs may arise suspicion of filariasis. Blood test. Perform blood tests to detect microfilariae. It involves examining a blood sample under a microscope to identify the presence of the parasitic worms larvae. Immunological tests. Some immunological tests such as antigen detection assays can help identify specific markers of the filarial infection in blood samples. Ultrasound imaging. Use ultrasound imaging to visualize the lymphatic system and identify abnormalities such as dilated lymphatic vessel or lymph node enlargement, which are indicative of filariasis. PCR, polymerase chain reaction. Molecular techniques like PCR can be employed to detect the presence of filarial DNA in blood samples, providing a more sensitive and specific method of diagnosis. Ultrasound imaging, blood tests, immunological tests, PCR, polymerase chain reaction. Treatment, antiparasitic medications, administration, antiparasitic drugs such as DEC or dithylcarbamazine or ivermectin to target and eliminate the filarial worms responsible for the infection. Ivermectin. Symptomatic relief. Provide medications to alleviate symptoms such as pain relievers for discomfort and anti-inflammatory drugs to reduce inflammation associated with the infection. Elevate affected limbs. Encourage lymph elevation to reduce swelling and improve lymphatic drainage, especially in cases where lymphedema is present. Hygiene and skincare. Emphasize good hygiene practices to prevent secondary bacterial infections. Regular cleaning and moistening of the affected areas can help manage skin related complications. Mass drug administration. Implement community-wide mass drug administration programs in endemic areas to treat entire population at risk, aiming to reduce transmission and the overall burden of filariasis. The next disease is malaria, normal cell infected RBC. Malaria parasite multiply in the RBC. It is a NOB. Disease caused by the pathogenic protozoan parasite Plasmodium. 100 species are known to infect man, monkey, rodents, reptiles, and birds. Human is a host. So, Plasmodium vivax cause malaria with low death. Plasmodium falciparum hold high death rate. Plasmodium malariae have very low death rate. So, Plasmodium falciparum hold high death rate. The incubation period of vivax and ovale malaria is 12 to 15 days, and that of falciparum malaria is nearly 12 days, and that of cotton malaria is 25 to 30 days. The life cycle of Plasmodium vivax is completed in two hosts, namely man and female Anopheles mosquito. In man, it lives as an intracellular endoparasite inside erythrocytes and parenchymatous liver cells, but in mosquito, it lives as an extracellular endoparasite in the gut cavity, salivary apparatus, and the hemocoel of various parts. So, the life cycle of Plasmodium vivax is completed in two hosts, namely man and female Anopheles mosquito. In man, it lives as an intracellular endoparasite inside erythrocytes and parenchymatous liver cells, but in mosquito, it lives as an extracellular endoparasite in the gut cavity, salivary apparatus, and hemocoel of various parts. It undergoes the asexual phase of its life cycle in man and the sexual phase in mosquito. Man is the pathogenetically affected host, and mosquitoes simply serve as a asymptomatic carrier or vector. The transmitters of Plasmodia are mosquitoes of the genus Anopheles. Transmission. Different pathogens have different modes of transmission, which are usually related to the habitats of the organisms in the body. For example, respiratory pathogens are genetically airborne, whereas intestinal pathogens are spread by food or water. Transmission involves three stages: escape from host, travel, entry into the new host. The mode of transmission of infectious diseases is classified as direct transmission, direct contact, droplet infection, contact with soil, inoculation into skin or mucosa, and transplacental. Indirect transmission, vehicle borne, vector borne, mechanical, biological, fomite borne, and unclean hands and finger. Pathogenicity. Malaria means bad air in Italian. Widespread transmissible disease in the world. There are about 100 million cases of malaria every year. Nearly 1 million cases being fact. The disease was endemic in more than 100 countries. The incidence of malaria is now under control through malaria eradication programs under the initiative of WHO. Transmission of malaria usually occurs when there is a combination of several conditions, including the sources of infection, vectors, susceptible population, favorable climate. The source of infection is a carrier of malarial parasite whose peripheral blood contains the mature gametocytes of Plasmodium. Based on epidemiological pattern, two types of malaria are there: stable malaria and unstable malaria. Stable malaria usually affects young children. It is transmitted with fairly uniform intensity throughout the year in community. Its eradication is difficult, and that's why it's termed stable. So, on the other hand, unstable malaria affects people of all age groups. It is transmitted only seasonally with varying intensity in a community which lacks proper immunity. Its eradication is easy. The primary attack of malaria show prodromal symptoms. They include nausea, anorexia, constipation, insomnia, then thickly coated tongue, headache, general malaria, myalgia, achargia, pain in joints, feelings of chills, etc. So, prodromal symptoms are followed by a series of repeated attacks called paroxysms lasting for 6 to 12 hours. Malarial paroxysms consist of three successive stages, namely rigor stage, chilling or cold stage. So these symptoms are there. Malarial paroxysms consist of three successive stages, namely rigor stage, chilling or cold stage, febrile stage, fever stage or hot stage, and defervescence stage, sweating stage. So chilling stage, fever stage, sweating stage. 2 hours, 4 to 5 hours, 1 to 2 hours. Figure stage shows chill, acute shivering, rapid pulse, high breathing rate, severe headache, lumbar and limb pains, nausea and vomiting. This stage is not always present and its duration is variable. During the febrile stage, the temperature of the body shoots up to 105 degree Fahrenheit or more. During the defervescence stage, body temperature falls very low, profuse perspiration starts, and the patient feels comfortable in a few hours. In vivax malaria, this stage regularly repeats once in 3 days for nearly 2 weeks. Usually, it occurs between midnight and noon. If proper treatment is not given, the patient's immune system would produce antibodies that would destroy most of the intracellular parasites in the erythrocytes. At the same time, the extracellular parasite would remain unaffected and the infection would pass to a latent stage. So, in such cases, the patient may be again attacked by the disease without fresh inoculation of the parasite. No fresh inoculation is needed as the blood is contaminated with this already. So, recurrent attacks will be there. The attack occurring with short interval called recrudescences and those who have long interval called relapses. Sporozoites via bloodstream, liver, merozoites, schizone, trophozoite, and MASH red blood cells. Symptoms of malaria: central headache, systemic fever, muscular fatigue, pain, back pain, skin chills, sweating, respiratory dry cough, spleen enlargement, stomach nausea, and vomiting. Symptoms recognition: common symptoms include fever, chills, sweats, headache, and muscle aches. If someone in a malaria endemic area experiences these symptoms, it could indicate malaria. Diagnostic tests: rapid diagnostic test RDTs and microscopic examination of blood smears can contain the presence of malaria parasite. RDT provide quick results and are often used in resource limited settings. Then species identification: malaria is caused by different species of Plasmodium parasites. So identification of the specific species is crucial for determining the appropriate treatment, as different species may have varying drug sensitivities. Medical history: knowing the patient's travel history to malaria endemic areas is important for diagnosis. Malaria may be considered if symptoms develop after travel to such regions, endemic regions. Then laboratory confirmation: in some cases, especially if there is uncertainty or severe illness, laboratory tests like polymerase chain reaction may be used for more accurate and detailed identification of malaria parasite. Treatment. Early diagnosis is crucial. Prompt and accurate diagnosis is essential for effective treatment. Rapid diagnostic tests and microscopy are commonly used to identify the malaria parasite. Then anti-malarial medications. Treatment typically involve anti-malarial drugs. Common options include chloroquine, artemisinin-based combination therapies, and other medications based on the specific type of malaria and drug-resistant patterns. Precautions for malaria. Complete treatment occurs. It's important to complete the full course of prescribed medication even if symptoms improve before the treatment ends. This helps prevent the development of drug resistant strains of the malarial parasite. And this is the same in the case with any disease, I guess. So you are expected to complete the course of that medication. Severity determines treatment approach. The severity of the infection influences the choice of medication and whether hospitalization is necessary. Severe cases may require intravenous drugs and supportive care. Then dengue. The dengue fever, also called 3-day fever. Dengue is a mosquito-borne viral infection characterized by flu-like symptoms. This is something caused by a virus, not a parasite. The earlier two things we learned was because of parasites, and this one is because of virus. 3-day fever. So dengue is a mosquito-borne viral infection characterized by flu-like symptoms including high fever, severe headache, pain behind the eyes, joint and muscle pain, rash and mild bleeding. So it is transmitted primarily by Aedes mosquitoes, particularly Aedes aegypti. So dengue virus, DENV, is a mosquito-borne viruses belong to the family Flaviviridae and the genus Flavivirus. So the dengue viruses consist of 5 serotype named dengue virus type 1, 2, 3, 4 and 5. DENV 1, 2, 3, 4 and 5 that are responsible for diseases. These serotypes are closely related but antigenetically distinct. DENV5 is a new serotype which has recently been described from Malaysia. Hota and Kimura were the first to isolate the virus in 1943 by intrarenal inoculation of serum from an acutely ill patient into suckling mice. The prevalence of dengue viral infection has been estimated that over 2.5 billion people live in the areas of risk with an incidence of 50 to 100 million cases per year, and several thousands of deaths are estimated to occur annually worldwide, resulting in 500,000 cases of DHF and DSS and 25,000 deaths. Dengue virus induces clinical illness ranging from asymptomatic or mild febrile illness, dengue fever, to severe disease forms, dengue hemorrhagic fever, and dengue shock syndrome. Infection with any one of the 4 DENV serotypes has the potential to involve all human organ systems and cause a wide variety of clinical manifestations ranging from mild febrile illness to severe and fatal diseases. Then symptomatic dengue diseases are separated into 2 different clinical syndromes, dengue fever and the more severe dengue hemorrhagic fever, DHF. DF was described as a non-specific febrile disease illness with prominent constitutional symptoms, while DHF was defined as a distinct syndrome characterized by increased vascular permeability, altered hemostasis, and hemorrhage. DF is also referred to as a break-bone disease due to its nature of severe joint and muscular pain. Following an infectious mosquito bite, there is an incubation period of up to 2 weeks, normally 5 to 7 days, after which the individual develops symptoms suddenly, and the illness typically follows 3 phases. An initial febrile phase, a critical phase starts 4 to 5 days from fever onset, followed by a spontaneous recovery phase. Then in febrile phase, patient experiences sudden onset of high fever accompanied by non-specific constitutional symptoms include headache, general malaise, nausea, vomiting, myalgia, and joint pain. In recovery phase, the increased vascular permeability and abnormal hemostasis are transient and usually resolve within 48 to 72 hours. Spontaneous reabsorption of fluid starts around 60 to 8 days of illness and progresses rapidly, usually concurrent with improvement in the patient's symptoms. Loss of hair has been reported during this convalescence. Eye pain, fever, muscle pain, headache, bone pain, nausea, vomiting, joint pain, and rash. Rash is also common. Primary infection with the dengue virus results in a self-limiting disease characterized by mild to high fever lasting 3 to 7 days, severe headache with pain behind the eyes, muscles and joint pain, and a rash. Then complications often occur within 2 days after the fall in temperature. Epistaxis, bleeding of gums, passage of black stools, rashes, maculopapular bruises, etc. Subconjunctival hemorrhage are indicators of increasing disease severity. A maculopapular rash usually appears 3 to 4 days after the onset of fever. Secondary infection with a different dengue virus serotype is the more common form of the disease in many parts of Southeast Asia and South America. The major clinical symptoms can include high fever, hemorrhagic events, and circulatory failure, and the fatality rate can be as high as 30%. So, early diagnosis of dengue shock syndrome is particularly important as patients may die within 12 to 24 hours if appropriate treatment is not administered. The major host factors that influence clinical manifestations are age. Constitutional symptoms become more prominent with increasing age. That adults complain of headache, retroorbital pain, and severe myalgia and arthralgia more frequently than children. Gender females have a long threshold of muscular leakage than males, although dengue is diagnosed more frequently in male than female patients. Female patients have a higher risk of developing GSS and dying from this complication than male patients, so that's something to be noted. Here you can see Aedes aegypti, Aedes albopictus, Aedes polyneesians, Aedes nivis. Pregnancy and transplacental infection. With the increasing burden of dengue seen among young adults, exposure to infection during pregnancy is becoming more frequent. So, clinical findings alone are not sufficient to make an accurate diagnosis of DENB, as several other infectious diseases may present with similar findings, which require the need for laboratory testing for dengue confirmation. Leukopenia, thrombocytopenia, increased hematocrit, and liver enzyme levels are common laboratory findings suggestive of DENV infection. Serological tests such as rapid diagnostic test RPD or enzyme linked immunosorbent assay ELISA are widely used. In Nepal, serological testing has been used as an important tool for diagnosis of suspected DENV infection during outbreaks. Symptoms. Dengue is characterized by symptoms such as sudden high fever, severe headache, pain behind the eyes, joint and muscular pain, rash, and mild bleeding. Then vector-borne transmission. The primary mode of transmission is through the bite of infected Aedes mosquitoes, mainly Aedes aegypti and Aedes albopictus. Then geographical distribution. Dengue is prevalent in tropical and subtropical regions, including parts of Southeast Asia and Pacific Islands and Americas and Africa. Then prevention. Preventative measures involve controlling mosquito populations through proper waste disposal, use of mosquito repellents, wearing protective clothing, and implementing vector control programs. Diagnosis often involve a combination of clinical symptoms, medical history, and laboratory tests such as polymerase chain reaction or serological tests to confirm the presence of the dengue virus or antibiotics. Treatment. Supportive care. There is no specific antiviral treatment for dengue, so medical care focuses on providing supportive measures. This include maintaining proper fluid balance, managing pain and fever with medications like acetaminophen, and monitoring for complications. Fluid replacement. Dengue can lead to dehydration due to fever and vomiting. So, intravenous fluid replacement is often crucial to prevent complications like severe dengue or dengue shock treatment. Early recognition and prompt fluid administration are key components of treatment. Pain management. Analgesics like acetaminophen are used to alleviate pain and reduce fever. Non-steroidal anti-inflammatory drugs such as ibuprofen are generally avoided due to the risk of bleeding associated with dengue. Avoided, not applied, avoided. Okay. So monitoring and hospitalization. Severe cases may require hospitalization for close monitoring and intensive care. Monitoring Vital signs, blood counts, and other laboratory parameters is essential to detect and manage complications promptly. Platelet transfusion, several cases with significant bleeding or low platelet counts, platelet transfusion may be necessary.